Hi friends, Angelica Vanetta, co-chair of Inclusive ICR. We are a coalition of over 220 employers in Eastern Iowa, all working together to grow the diversity and inclusion of our workforce, to create a space where employees feel a sense of belonging, included, and valued. Inclusive ICR is a proud sponsor of the Diversity, Equity, and Inclusion track of the Iowa Ideas Conference. As you participate today, be sure to connect with other Inclusive ICR champions, as we'd love to share information with you about our upcoming coalition meetings, projects, and how our work is impacting positive social change in our region. Be sure to visit our website at inclusiveiowa.org for information on upcoming events and to sign up for our e-newsletter. Thank you and have a great conference.
Welcome to Iowa Ideas Session 3 on mental health. I'm your moderator, Trish Mahaffey. I'm a reporter with the Gazette. I cover state and federal courts. Today, our panelists are going to talk about access to mental health in Iowa. What are the barriers? Do we have enough crisis services? Where are the gaps in services? And what staffing and workforce challenges do we face? We also want to talk about some good things that are happening across the state and how to build on those efforts. If our viewers have any questions, please put them in our chat and we'll address those near the end of the session. We understand the topic of mental health issues may have an impact on our viewers. I want to take this time to share some resources our panelists have recommended for anyone who that is or knows someone experiencing mental health issues. I'll share now, and our tech host will share that in the chat in Hubia. Let's see. 988 is for anyone in crisis and needing to speak with or text with a trained crisis professional. Iowa Warm Line, it's 844-775-9276 or WARM, staffed by individuals with lived experience who provide non-direct support for those experiencing a crisis. We have Iowa Office of Recovery Services, 855-622-4692 for those looking for sources or help. Or you can also go to the website, and it's orsiowa.org. And then we also have Foundation 2 Crisis Line, 319-362-2174, and that's in Cedar Rapids. And then anywhere else in Iowa, you can call 1-800-332-4224. I would like to thank our sponsors today, ITC Midwest, Cedar Rapids Bank and Trust, and Inclusive ICR Iowa. So let me get to the panelists finally. And I'm going to give them a chance to also explain their connection to the session today. We have Ann Carter. She is the Health Equity, I can't talk today, I'm so sorry. Ann Carter is the Health Equity Program Manager with the Linn County Public Health. Hi, Ann.
Good afternoon.
Would you like to explain more of your job?
Sure, I'd be delighted to. Thanks so much. And thank you for all who have joined us this afternoon. I serve as the Health Equity Program Manager for Linn County Public Health. It actually was a newly created role when I stepped into it about a year and a half ago. And in part was a response to the Board of Health position statement from the summer of 2020 declaring racism a public health crisis. And so whether we're talking about mental health or other health outcomes, we know that right here in Linn County, we do experience disparities on by race. And so my role is to really bring together our partners and community members, and I look forward to talking more about that.
Okay, great. And then our next panelist is Jim Hayes. Jim, would you like to explain your job? Oh. Jim, I think you're muted.
Somehow I got muted. I got muted and I didn't have permission to unmute it. So I was stuck in limbo here. So there's my great technological start. So my name's Jim Hayes, and I'm the Executive Director at Mind and Spirit Counseling Center in Des Moines. We are an organization of about 30 therapists with a variety of services, so psychiatry and psychology, and lots of therapists, in addition to a good bit of work that we do in leadership development in the community. So it's great to be here with you, and I'm looking forward to this conversation.
Thank you, Jim. And Leslie Carpenter.
Afternoon. I am a family member advocate. I have retired from my career as a physical therapist to now do advocacy on a volunteer basis in a wide variety of ways, including running our own agency called Iowa Mental Health Advocacy. I serve on the NAMI Iowa board and multiple other boards and committees. And I'm a lobbyist, but I'm not paid by anybody at the Iowa legislature. So please don't be too impressed or too offended by that. And I have a son with a very severe schizoaffective disorder, and that is my tie to this conversation today. So thank you very much to everyone for being here.
Thank you, Leslie. And then our last but not least panelist is Carol Mead.
Hi, thank you for having us this afternoon. I'm the Director of Behavioral Health Services here at Unity Point St. Luke's Hospital here in Cedar Rapids. I've been in this role for almost 7 years. At St. Luke's, we have 3 inpatient psychiatric units for kids, adults, and the geriatric populations. We also have a number of hospital outpatient departments, step-down programs from inpatient to outpatient services. Thank you.
Thank you, Carol. And we're going to start off with Leslie. She's going to give us kind of a brief description of, or brief history of mental health in Iowa.
So brief. We have made quite a bit of progress over the last several legislative sessions in terms of in the state. As people know, we've changed over to getting funding from the state with oversight from HHS centrally to help ensure that certain services are being provided across the state, hopefully in an equitable fashion. We have been able to get increased reimbursement rates for people who are seeking mental health services. We've been able to get increased tiered rates for intensive psychiatric care so that hopefully folks approaching in a psychiatric crisis have access to more acute care beds when they need them. We've done several things to try to get increased staff. We all know that we have a huge staffing shortage across the state. We've done things like adding psychiatric residencies at our state facilities and loan forgiveness to try to get more mental health professionals to work and live in more rural communities that are currently underserved. So we've made some headway in addition to the implementation of 988, which we all know is the number that we want folks to call when they're in crisis so that they can get connected right away to a mental health professional rather than having a law enforcement response. So that's kind of an overview from a big standpoint, a big viewpoint. I would say that the challenges are still there across the state for people that are seeking care, because some of these changes take a huge amount of time to implement. And the other one that I shouldn't overlook is the complex needs law that was passed in 2018, specifically to address the needs of folks with more severe illnesses. So calling for the access centers, which we've been able to open up, but mostly in central to eastern Iowa. Getting more mobile crisis, getting more intensive services, residential homes for folks with complex needs. We have gotten a lot of laws passed. The hard part is getting it implemented and getting it implemented again in a more equitable fashion across the state.
And then, Ann, do you kind of want to take it from there on the equitability? If you can talk about that a little bit.
Sure. So health equity really just means making sure that everyone can achieve their best health. So it's a combination of, if you will, access and then also health outcomes. And so through the Office of Health Equity here at Linn County Public Health, we're working with people who face greater health risks, and then also with organizations to be able to remove those barriers to good health, create solutions, and help make Linn County a place of belonging, a place of good health. And we know that in Linn County that suicide is the 10th leading cause of death in Linn County. We have, as do all public health or local public health departments, have our community health improvement plan. And in our current plan, as we were doing the analysis leading up to that, mental health was the top health concern voiced amongst every demographic group. Some of you may have heard the statistic nationally that 1 in 5 adults will experience a mental health issue during their lifetime. That's a fairly common statistic. Well, during the first year of the pandemic, 4 in 10 adults reported symptoms of anxiety or depression, and that was up from 1 in 10 adults the year before. And so I often think about this just in terms of what does mental health mean to the broader community, and maybe the silver lining, if you'll allow me to say, of COVID-19 is that mental health has become much more prominent in mainstream media. And I'm a strong believer that if we make it easier to talk about, then it is easier to act upon and work together on solutions.
Right. And do you think, I know that you were involved with the Make It Okay campaign?
Yeah.
Okay.
Yeah, absolutely. Would love to talk about Make It Okay, which is a community campaign that's focused on eliminating stigma and raising awareness. So it's kind of built on this model of learning about mental illness, talking about it, and then sharing. And again, I kind of summarize that as normalizing the conversation. And that is a campaign that originated in Minnesota, came to Iowa in 2019 by way of the Healthiest State Initiative. I happen to work for an employer that is a Make It Okay workplace, as are some of my colleagues here on this call. And it means that we at Linn County value being able to talk about mental health, making it easy for our employees to find support. I also had an opportunity to participate in rolling out a reimagined Make It Okay campaign, because it was recognized that there are some nuances. While stigma may be an issue across populations, we noticed that there were nuances when it comes to, for example, Black and African American communities. And so we had a statewide group that came together to reimagine that campaign, think about not only what are the images that are shown, but what does the language look like? And so it became dubbed as Back the Black. And this was rolled out last May, and we refer to it as a campaign developed by Black Iowans for Black Iowans, and really addressing, that intersection of faith and mental health, if you will, as an example.
Okay, great. Well, Carol, would you like to talk to us a little bit about inpatient care? Like, what are the gaps we're still missing there?
Absolutely. Absolutely. So, a lot has changed in the inpatient acute care world also in the last few years. One of the side effects of COVID-19 and our staffing challenges is that we can't open all of our beds. Prior to COVID, we had about 68 inpatient psychiatric units here at St. Luke's Hospital in our child, adult, and geriatric population. But to mitigate the risk of COVID-19, we had to reduce all of our beds to single occupancy. So that was the initial sort of cut. It almost cut our beds in half. Our battle now is to hire staff to be able to appropriately staff those units and safely staff those units with qualified psychiatric nurses and other practitioners to be able to care for these patients. And so unfortunately, us, along with other hospitals across the country, haven't been able to do that. One of the last times I looked, there's something like, I don't know, close to 800 licensed beds in the state of Iowa, I think, but less than 600 of them are open, for a variety of reasons, but at least for me and other colleagues of mine, it's because of the challenge to staff those units with qualified nurses and other mental health providers. And so that That continues to be the challenge. So the issues that you hear about in other places in the country happen here as well. Patients come to our hospital in a crisis and in need of services, and many times we can't admit them right away because we don't have a bed open for them. And so these patients may end up having to spend hours or days in our emergency department. We are fortunate in the Eastern Iowa corridor, so much more fortunate than other places in the state, because we do have other resources that sometimes we can assist patients to get to. We can send them down the street to Mercy if they have open beds. We have the University of Iowa close by, and more outpatient resources than many other areas do. So that continues to be one of our biggest crises. And then on the other end, one of the issues is appropriate discharge planning for many of our patients. And that's for all populations, really. I think we have patients on our adult unit who really have complex needs, and finding a really good, safe discharge plan for those folks can be a real challenge in the state of Iowa. It's hard to get patients to the MHIs, for example, and other facilities who can accept patients with complex needs. There aren't enough of them, and they face the exact same challenges we have here, hiring appropriate staff to take care of these patients. On the other ends of the continuum, we could spend a whole session, and if you get me going, I'll take the whole session, talking about children and the services that we continue to have huge gaps in our state in terms of child services on the crisis end, as well as on out after they no longer need acute services. And just as challenging and high of a need, I believe, is our older adult population. We have a lot of individuals on our older adult unit who there's just not an appropriate or acceptable discharge plan for them. And so they stay in the hospital much longer than they need to stay. I'll pause now and let someone else have a say, but definitely some gaps in our services here.
Sure. I was to say, also, Carol, we had talked the other day about that, that there may be enough beds, but maybe they're not in the right place where they need them.
Absolutely. That's a really good point. So many times there's open beds in different places of the state, but I'm a mom and my child is experiencing a mental health crisis, and so I come to St. Luke's Hospital, which is my local hospital and where I want to be, and I'm told that we don't have a bed here, but there is a bed in Sioux City. Would you like to transfer to Sioux City and have your child receive care there? I live in Cedar Rapids. All of my outpatient services are in Cedar Rapids. I work in Cedar Rapids. And so for me to have my child go across the state, or even as far as Des Moines, is going to be a terrible burden for me as a mom, for my child, financially. All of those things are going to be a burden. So that's one of the other concerns that happens, is there may be a bed someplace in the state, but it's not the right bed at the right time for the right person.
Yeah. And I can certainly understand that, because I can't imagine a parent, and financially, how could they do that?
Absolutely. Yeah, transportation is an issue. Connection to your community and your tribe that hopefully is around you, supporting you, is not there.
Sure. And then, Jim, do you want to talk a little bit about about staffing shortages and about being able to get the right clinicians here?
Sure. And thanks again for getting this organized, and for all the folks that are out there listening. My hope is that we all get a little bit energized by our time together today, because this is one of those things that takes all of us. I'd like to start on the level of a little bit of empathy and understanding, as you were just talking about that, Carol. In a mental health crisis in my own family, one of our kids had some issues. We couldn't get anything in Iowa, and so my wife and I both work. We had to figure out how to get to San Diego and spend a month there, and we had enough privilege that we could try and figure something out on to make that work. But it was zaniness trying to figure out what to do, but what you will do for your kids. And I continue with the good news, bad news on the empathy side. The good news is we have to reduce stigma through things like Make It Okay and some of the other stuff that's been discussed here. But that has led to an increase across all demographics of people seeking mental health services. So good news, right? We've reduced stigma. And then you make the call if you came to our place. We are a nonprofit. We try to help as many people as we can, regardless of their ability to pay. So Ashley and Emily, who are sitting a few feet away from me taking phone calls right now, are getting a call from a family that's in crisis, whether it's for a child or for an adult, and they're going to hear that they've got a long waiting list. We'd like to help you. And then we give referral sources. Yeah, I've called them. Yeah, I've called them. Yeah, I've called them. And so now this crisis that you have that needs immediate attention is like maybe 6-8 weeks down the road before you can get in. For us all to enter into that experience, a lot of us have experienced it, but you can imagine how hard their job is to say no to virtually every person that's coming in and then refer them to crisis sources or things like 988 or things like, I saw Peggy Huppert on here somewhere, like to NAMI, to some peer-to-peer support groups that, just getting any help that you can get for anybody. But that experience of hearing no over and over again, and the people who are in the workforce saying no over and over again for folks who are completely committed to this mission. So that's one of the good news, bad news. The other piece of it is when we think about workforce in rural Iowa, thank goodness for the pandemic. I mean, that we got telehealth insurance reimbursements to happen for that. So people who used to drive to us like 3 hours each way to come and have a 45-minute or an hour session now can just hop on their computer and get that. So I hope that's something that we can continue to provide, especially for those sort of mental health deserts where there's no provision of care. So in response to the question about workforce, there just simply isn't enough. In Iowa, anybody that wants to go do an internet search will see that we are below 45 out of 50 or 51 in just about every category per capita of mental health professionals, whether it's a psychiatrist, a psychologist, a mental health professional, therapist. So that's why it's hard to get help. Some of that's related to economics and reimbursements. And I know Leslie's worked hard on some of this and some of the changes that have happened, like new increases in Medicaid rates to help people get help. That might attract some workforce for us. But I want to get at the DEI component of it and just take a minute on this. When we think about the increases across all demographics and people seeking folks who are coming from their communities to address some of these mental health issues that they have, that's where we really have a crisis too in our state. That as demographics change, it takes a long time for somebody to get trained in this stuff. If you're not aware of it, it's years. And one of the crises that I've encountered that we're trying to figure out as an employer is about 57% of people who get their master's degrees in this don't get licensure, right? And what are the causes of that? Well, one of them is understandable. It's social workers. So you can be a social worker and go out and start practicing without licensure and do a lot of stuff with that degree. But take those people off, and then you've got all these other folks. What's going on? Why can't I get to licensure? Sometimes it's about economics. Sometimes it's about race and gender. Sometimes it's about, like, I can't find a supervisor who will take me because I live someplace where it's hard for me to get to a supervisor. So there are all these hurdles that exist for people who are absolutely qualified to become licensed, but they have to do a year of internship. They have to do a couple of years of provisional licensure, and to step out of the workforce and kind of have very little in terms of income for that amount of time, we have lots of burdens. So some things have happened to improve that, like forgivable loans or improvements that we need to do in terms of providing supervisors to folks. But I think on the level of, if we're going to have more representation from communities of color in this profession, we have to be thinking way, way upstream on how do we attract people to this and how do we make it possible to remove some of those barriers for people who might be interested in this but simply can't do it because of those barriers that they have. So we don't have enough folks. I can guarantee you, any employer around the state, ask them what their main issue is, and it's like people. Carol talked about it in her staffing. We have it for our staffing. I'd love to hire more people. When we have a search, I had an experience. I lived in higher ed for a lot of years, and we'd have like hundreds of people apply for one position to be a college professor. We might get 2 or 3 people apply for an opening that we have here. Just they've already got jobs. They move around. It's a crisis for us, and figure out how do we get more people into that pipeline. So I'll stop there and enjoy the rest of the conversation as we move along.
I'd love
No,
to
is
pick up there.
go ahead.
Yeah, I really appreciate that Jim is lifting up the complexities of building a pipeline and building a visibly diverse pipeline, as well as diverse in ways that aren't visible. And a couple of thoughts that I want to share, because that work on building the pipeline and that upstream solution, if you will, is critical. Until we get there, there's other stuff that needs to happen a little bit lower, if you will, on the stream, and in terms of even just what is the level of cultural humility, to use a buzzword, if you will, of our dominant culture providers. Because I know that from personal experience and from statistics that people wait on average 10 years before seeking help. And so when Jim and others have described what it's like to, make that, you finally make the call, and then you're told there's a wait, or you have to go halfway across the state or all the way across the state. And oh, by the way, I really want someone who looks like me. I want somebody who understands my culture. I know that working on that pipeline is something that cannot stop. I just want to share from a personal standpoint. I waited 10 years to get help. I ended up with a bipolar type 2 diagnosis. I've now been taking medication for 15 years. But you know what? It took me a long time then before I would even start talking about it. And so this is where my passion comes from in terms of normalizing the conversation, because as I reflect back on those years and thinking about my quality of life or the impact on my career or my family, what's really important to me now is to make it easy to talk to my children and my grandchildren about, oh yeah, Grammy has a therapy appointment, or Grammy's going to the psychiatrist. And in my case, none of my providers look like me, but I've found that I need help more important than I need somebody who looks like me. That may not be a popular thing to say, but that's sort of the reality check of making sure that people get the help that they need.
Yeah, and that's really sad that happens, that you have to do that. I mean, is it because of, you can't get people to come to Iowa, or is it just like that's happening everywhere? As I know it is, but I mean, is it something about, is it harder to get people to come here? I'm just asking that question. I don't know if it is or not.
I think it probably is. I think we're pretty well known as a state that has a pretty broken system. And I want to say that in a way that doesn't criticize any of the people working within it, because we have many amazing, wonderful providers and people at HHS throughout the whole state working to do this work. I want to say that very clearly. But we are ranked very poorly in terms of every measure of our mental health care in the state. And so I do think it makes it harder. And that's part of why I keep pushing that we need to both build up our workforce, but we also have to build up the system for them to work in. I wouldn't want to go to work in this system because I know how difficult it is and how broken it is. It's really difficult to take each individual patient and provide the services and the beds that they need at the time that they need it, for the length of time that they need it, across the course of their lifetime, because these are chronic illnesses, right? They're not something that comes on one day. You diagnose it on day 2 and you get it cured on day 3. These are lifetime illnesses that come and go and wax and wane. And I think we have to both build up the system and recruit the staff. It's a simultaneous project. It really is. And the other part of it I want to touch on is, Carol was talking about this idea of people going across the state to a bed in Sioux City. That's a 4.5-hour drive from Iowa City. How do I know this? Because that's where my son is now, at one of those intensive residential service homes. 4.5 hours there, 4.5 hours back. But for acute care stays, when somebody gets transferred to a hospital across the state, The other problem with that is that they are going to get kicked back out as soon as that hospital could do it, without any follow-up, without any tie to an outpatient provider, without any education to the family about how they can help that person to do well. And that has to change. We have to provide a means of allowing for people to have appropriate discharge planning, even within the broken system. In the state of Michigan, I just learned that they have actually put that into code. And a judge can hold the hospital in contempt if they are discharging people to the street. And I think actually there's a need for that, because if we did take it one person at a time and create the plan of care and have accountability built in with that for where that person goes next, it makes a huge difference in terms of that one person's outcome. And if we thought about that with every person we try to provide care for, it could make a difference. It really could, one person at a time.
Sure. I was gonna say, Leslie, do you want to share a little bit about the experience you've had with your son? The problems you've encountered and
Sure. I'm happy to share that a little bit. He's been sick for 16 years, and he's been hospitalized 26 times. He has lived in every single setting, including our home, but he also finally, 14 years into his illness, got an extended stay at the state hospital in Independence. He only got worse, though, for those first 14 years, even though we were actively, assertively advocating to get him the care that he needed. But at the state hospital, he finally got an extended stay with comprehensive, structured, secure setting care with regular visiting with his psychologist there. And finally, he started to improve. My heart breaks that there is only 64 of those adult beds and 32 of those child beds, of which only 28 are staffed, right? So while our son was there for 2 years, because there was no place to send him to once he was ready, right? Again, the same problem that Carol mentioned earlier. What I knew was that prevented other people from getting into one of those beds. We desperately need more of those beds. Our state psychiatric hospitals are very different than our Glenwood, right? And we need to have an openness to understand we need some of that long-term care for the people who really need that. And if we had that, then we would have more availability at the acute care hospitals for the people that are urgently needing to get into their doors.
Yeah, I'd like to chime in just a little bit, Leslie, because I 100% agree with you. And I'll own it from my hospital, we can and need to continue to work on having appropriate discharge plans for all of our patients 100% of the time. The challenge, and this I think is also part of a system area issue, is when a patient stabilizes, we're told by the payer they're stable, it's time for them to go. And so from an institution that also needs to, keep our doors open, and we want to, so we can continue to take care of these patients who we all have a passion to take care of, we have to make some hard decisions. We want to have a really good discharge plan every time, but how many days can we go without getting paid on how many patients? And so I never advocate for, just sending someone out. I never, and I hope that doesn't happen. Do we sometimes know that we're sending people out with a less than fabulous discharge plan? Sometimes, sometimes we do, because at the end of the day, sometimes we have to do the best that we can do with what we have in our community. So in terms of holding the hospital accountable, great, but we also have to hold the payers accountable, because we can't do it without them. We also have to hold some of the outpatient services accountable as well. And I will say, in terms of a win in Lynn County, I think we have done just a fantastic job of building relationships and bridges with our outpatient providers. I've seen at least one person on here from Abbey Health who has recently integrated with Unity Point, but I know that they work exactly the same with Mercy Hospital down the street. It's not unique to us. we can collaborate and work together to both bring somebody in really safely. So sometimes there's patients out there just like, you know, any other condition who maybe I wait too long to come to the hospital, and so I'm pretty dang sick when I need to come in. So how do we safely bring them in, minimize that time in the emergency department, get them upstairs, get them taken care of as quickly as we can, and then safely and with a nice warm handoff, get them back to their outpatient area. We have done really a fantastic job of building those bridges here. And so I feel like with maybe not a lot of additional resources, we've tried to figure out how to make that work here in Lynn County. The mental health access centers in our area, again, we're so fortunate. We've got one down the road in Johnson County. We've got one here in Lynn County. That has also helped provide another place for some individuals, adults, again, we're just talking adults right now, to go when they're in a crisis. And we don't have that resource for youth in our community. And so if I'm a parent and I'm like just plugging along, working my tail off to try to get services for my child, and we reach a point where it's not safe anymore, the only thing I can do is go to the hospital. If I'm in that crisis, you know, I'm going to call Jim and they're going to say, oh yeah, you're probably right, you need an appointment now, and here's an appointment, you know, 2 or 3 weeks out. Well, I'm in a crisis today, right now, you know, Thursday afternoon. And so coming to the hospital is really what needs to happen. And we would love to be able to provide really great care here all the time. But with 14 beds, it's really hard for me to provide care for all those folks.
That's really true. And thank you for pointing out the difficulty with the payers. I completely agree. I know where that very difficult pain point is. It's part of why I'm really trying to push that we actually codify that the treating providers determine length of stay and medical necessity for different levels of care instead of the insurance companies, because the present system, the status quo, isn't working.
It's not working. Absolutely.
Yeah, I would add to that, if we're, talking about equity as well today, that if you do a step back from the system, from some of the, crisis stuff that we're talking about, it's working if you're a person of privilege, right? So if you just pay fee for service and scratch a check to your provider, they can make a great living and you can get great service. You can even do some things. I know, like a provider who's in New York who got licensed in Iowa just to do that kind of thing because they knew that there was a great market here. So people who have resources can work around the system and find ways to make it work for them. But for most of us, that's not an option. So that's another inequity that's going on. People can make a really good living doing this kind of stuff. Open a private practice, just take fee for service. Don't mess with all the insurance stuff that goes on, and they can make a great living. I mean, and they'll have a full caseload doing it just that way. So there's an imbalance in the people who can access quality services as well.
That's true. I mean, Anne, do you have anything to add to that?
No, but
Okay.
I actually want to go back to what was going through my mind is, yes, it's a little bit easier when you're in a position of privilege, but it's still hard. But it's just navigating the system. I was also, Trish, thinking back to your question about, is it that people don't want to come to Iowa? I did a quick Google on the side here. And now this is according to the American Psychological Association, that 4% of psychologists, 2% of psychiatrists are Black, 7% of marriage and family counselors, 11% of professional counselors. And so that doesn't even account for other races or ethnicity. So I would imagine that if we were to look at a heat map of the United States, that 4% of psychologists are going to be concentrated in large metropolitan areas and not in Iowa. So it's a combination of the population. The pool is low, as Jim pointed out earlier in this conversation, and then also the desirability or perhaps lack thereof in Iowa. I guess what I wanted to lift up next is, as we talk about what's needed from a policy standpoint and what the clinical needs are, some of the work that we are doing at Lynn County Public Health is very much focused on the community aspect. So mental health is one of the four priority areas of our community health improvement plan. And it's specifically focused, and some of you may be aware are familiar with your own county's community health improvement plan. For Lynn County, it's runs on about a 3-year cycle. And for this particular plan, we're looking at how can we engage community members and leaders and non-clinical partners to develop solutions. Drilling down a little bit even deeper, a project that I started leading last year, I mentioned my role was created in part in response to our Board of Health declaring racism a public health crisis. And so I was able to convene our healthcare partners. So both of our hospitals, Unity Point, Cedar Rapids, and Mercy, as well as Eastern Iowa Health Center, just to start by examining what does that really mean, racism as a public health crisis. And we agreed that we would sort of examine that, collaborate, and we kind of looked at geographically where we reside in the city of Cedar Rapids, and compared that to the redlining map, and compared that to life expectancy and other, data points, and ultimately agreed that we would focus on how racism impacts mental well-being in the community and how our local healthcare system can provide, do a better job of providing culturally informed care and promoting a place of belonging. So the next phase now is inviting in community members who identify as having lived experience with racism and that are willing to come alongside and co-create and really look at both what are some clinical solutions that are of a clinical nature and what are some solutions that are of a non-clinical nature. So that work is just getting underway, but it's an uphill climb.
Yeah, I can imagine. Anybody? Did we hit all the points that we were going to talk about that we talked about in our early session?
I think I just want, for just a quick second, represent something that hasn't come up that in terms of systemic change we really need to address, and that's the shortage of psychologists too. And because so many triggers for systems to get the services that people need require psychological assessment, there's a block for people who need these services, particularly for kids that do I have ADHD or autism? I'm on the spectrum or something like that. That getting those tests done, that some of those services are out there, but they can't get the services because there isn't a psychologist to do the assessment to say, here's the diagnosis. So it's another workforce issue for us related to that, but one that hasn't come up today. And this is for like outpatient stuff. Great organizations like here in Central Iowa and Eastern Iowa as well, Child Serve. They've got lots of great services they could provide, but they have to have somebody who's assessing that beforehand in order to get the services going. And nowhere to go with it. It's just another issue that we have to face as a community.
Is that happening pretty much across the state? Do you think?
I think it probably is. I think that's a fair statement. And I completely agree with Jim that we need to be doing more in terms of investment in the programs that are developing people to become psychologists, to become psychiatrists, to become social workers, to become nurses. We could be adding a lot more financial investment into a lot of those programs to help grow the workforce. Again, that takes time, but it would pay off over the course of time if we could continue to do that. I'm happy to share some other ideas for solutions if people are interested. I think definitely another thing that we should be looking at is having more coverage, especially from Medicaid, for people to get the things that we know help people in the long run, to help keep them out of crisis, right? Helping to pay for things like getting them connected to other people, getting them connected to having a purpose, whether that's helping them to get back to work or whether getting them involved in volunteer work. I will tell you that my son at the state hospital had a whole lot more community. He had a lot more things to do. Now that he's out in the community, he's actually much more isolated. He's much more bored. He doesn't have access to good connections with other people on a regular basis. And that's a limiting factor that we know has to be addressed. So of course, we're working to advocate for that to happen where he is now. But it's challenging because they say, well, for this level of care, we can't really get reimbursement for some of these things. Well, let's change that, right? If that's the case and we know it works, let's change what we can get reimbursement for. And yes, these are big, challenging things to do, but if we really are committed to improving it, we need to do that. We need to take on those challenges. The other thing I would say is that we have lots of hopeful things happening in pockets across the state. Here in Johnson County, we started the first assisted outpatient treatment program in conjunction with the first civil mental health court for people who don't know they're sick. So they're engaged with intensive case management as well as regular conversations every week with a judge. And with that intensive case management, lives are being changed. We're helping people to get the level of care that they need and helping them to gradually make that connection between being engaged in their therapy, staying on their medications, and being able to stay out of the hospital. So intensive case management, we need to get more payment for that as well. It really does work. And we need to spread these types of programs across the state.
Yeah, I heard the mental health court's going really well. And how many are there now? There are participants, because it was a higher number than they thought they were going to get.
Well, the last meeting that I attended when we had our monthly recheck with the planning team was about 9 patients. The goal by the end of the year is to get to 15.
Okay.
And we're hoping we only have one of these in one county for the state, but we're hoping to spread it across multiple counties across the state. So it doesn't depend upon where you live to get access to that type of care.
Sure. And it is like the pilot program for that.
It is.
Sort of. Okay. When did they start? Was that August?
We started in May with
May,
seeing
okay.
patients, and we got funding for a 2-year pilot from the East Central MHDS region. And we're very grateful for that funding and support.
Sure, that's great. We did have a question that came in that I might give you guys. Somebody's asked, if we have a stronger workforce around licensed social workers, is there a way to leverage that to fill some gaps using integrated behavioral health warm handoff approaches?
Yeah, I think having more social workers working collaboratively and integrated in various settings would be fabulous. I think it would help us here in the hospital, having nice warm handoffs to our outpatient community, having social workers in primary care offices who could help identify and help connect folks at the beginning of when they're starting to experience some symptoms. One of the challenges with that, we'll go back to what Leslie was just talking about, people don't pay you for that. So,
right.
So it goes again to how do we have these really good ideas, how do we put that in place and ensure that it is something that is that the organization can maintain. We want to provide great care for all of our patients all the time. And how do we do that in a way that also is, fiscally responsible and helps us keep our doors open? So I think there's opportunities for that. And I think that the state and the country are looking at new ways to provide some of that care with the CCBHC changes. And don't ask me to speak too clearly on that because that is not my area of expertise. But funding our community mental health centers in a different way so that they can better wrap their arms around the people in our communities and make sure they get those folks the services they need in a way that's not just a fee-for-service sort of opportunity.
Right. And that's the real potential of getting us to be a state that is considered one of the demonstration states with certified community behavioral health centers, because with that, it provides funding for some of that work, for that case coordination that needs to happen in a more intensive way. So we're really hoping that Iowa does end up being one of those states that's granted that funding. Everybody keep their fingers together. And also I would say that there is potential to change what gets reimbursed and what doesn't get reimbursed. if we all join forces and work collaboratively during session to try to help create these changes. I do believe it's possible. We have to believe it.
I think that's where, a lot of systemic change needs to happen and having funding for it. But I also, I'm a big believer in civic engagement. Like, how can I be a part of the solution for each one of us that's in this meeting today, not just professionals? So you think about partnerships of something like, could we reach out and do something, have a unit on mental health first aid? So we have a better sense of what am I looking at here? How can I get help for this person, and having employees do that, or the make it okay stuff that we talked about earlier. There's an organization called, we do a lot of partnerships with faith communities. So working with religious leaders on a thing called Soul Shop, that's about suicide prevention, where you could have in your community sitting when they're at some kind of a gathering on a weekend, someone who lost a parent to suicide, someone who did a suicide attempt at some point in their life, and somebody who's considering an attempt, and they're all sitting within a few feet of each other. And how do we get some questions to come up, or some help for one another that could happen in a place like that? There are things that we can all do. I mean, I think the NAMI stuff, I'll give them a shout out to, for the peer-to-peer kinds of things while you're waiting for a therapist. There are wonderful support groups of people who have been through a mental health experience. And I mean, just like Leslie, because of your lived experience, you don't have the degree or the license necessarily to do that, but you're more of an expert than a lot of people who do because of your lived experience. So how do we get some of that wisdom out in the community as well, and promote those kinds of things, in addition to like 988 that we talked about today? If you know somebody who's in crisis, everybody should have that number memorized. Tell everybody you know about it. You could save a life. So that's all of us. That doesn't take experts or politicians or anything else, but like, what's something I could do to make a difference in this arena? And that's a question for all of us.
Since you brought up NAMI, I'm going to give a shout out that the NAMI Iowa conference is coming up on November 8th. And within it, there are different tracks of education that are being provided. And some of it is on DEI. So even though we don't have a real diverse workforce, it doesn't hurt for all of us to learn as much on this area so that we can be more culturally responsive in how we are interacting as well. So any person can go to these types of conferences and learn more and learn about what's available out there. And yes, I would also mention the family to family class for anybody who hasn't ever attended it with NAMI. It literally changed my life and helped in innumerable ways in terms of processing our grief over losing our son to this illness, right? And figuring out our way forward to keep supporting him, but not feeling completely solely responsible for his ultimate outcome. And that makes a huge difference in our ability to navigate and still actively advocate for him, but still be healthy in doing so.
If you guys could do something to change the system, what would it be? Maybe something beyond what we've talked about, like what would be your dream?
One that hasn't come up today, I'll throw out, that actually wouldn't be that difficult. It's somewhat complicated, but is the licensure issue that we brought up today. And it's state to state to get licensure. And so having to be licensed in more than one state, and how to get national licensure. So we're not as worried about, I only have my provider in Iowa, that through telehealth experiences, people could go where there might be a greater workforce to set up an appointment for it. There are some companies out there that are doing that, but they have to have their respective providers in a license in their state. But if we could find a way to get around the control issues, which I know they're very serious, of like, my state doesn't agree with the way you do it in your state kind of a thing. If we all got together, even as a nation, for something like that, that would be a wonderful opportunity, that you'd have a much larger opportunity for getting services as a result.
Sure.
If I were to say the number one thing that needs to stop happening, it's arresting people for the sin of being sick with a brain illness and having people end up in our jails and prisons. We have to stop doing that. We have to figure out ways to safely provide treatment that keeps staff and everybody safe, and not having people call the police just because someone is really, really sick with a brain illness. There's my pie in the sky wish.
Sure. And I think the access centers have helped some of that, or they're trying to. So I'm hoping that, more come out and and that just, continues to go.
They have absolutely helped that. We have stats from GuideLink. I'm on their advisory board. The number of people that are being diverted from jail or from no care at all is massive. They are making a huge difference, and we're ever so grateful for the good souls working at both, well, all the access centers.
Sure. And I know they were having staffing issues too, so I hope that, continues to improve too.
I think one of the things that I would love for us to improve on is really early identification and treatment. And part of that I think goes back to what Ann has talked about in terms of stigma, but some of it is even sooner than that. Educating our pediatricians and early educators on early signs of mental illness or concerns within younger children, just like any other condition, if early identification and treatment and consistent treatment is going to help individuals in the long run. If I'm a diabetic and I don't take care of myself for years and years, by the time I finally come to the hospital, I'm going to be pretty sick. But if I identify that early on, get preventative treatment, then I'm going to do better in the long run. The same is true for brain health. And so I think we haven't spent enough time focusing on how do we wrap our arms around the youth and young people. It's complicated, although it's complicated everywhere. Kids come with parents, kids come with a whole package with them, but I think that we can figure it out. And part of it is figuring out how do we educate those people who meet these kids at a young age and start to identify that. It saddens me tremendously when I see people come here to the hospital really wanting and needing help, and it's really their first time reaching out to the system. And sadly, what makes me even more sad is sometimes we have to say, I agree, you're in crisis. This is a really bad situation, and I don't have a bed, and you don't really meet criteria to be admitted to the hospital, and there's really no place else for me to have them go. And you can just, I feel it in my gut how those parents must be feeling in that moment.
Sure. Carol, can you say how often that happens?
How often does that happen?
Yeah.
More than once a week. I mean, often, a lot. Yeah.
And I'm sorry, Anne, you were going to say something.
No, I was just going to go back to my normalize the conversation. There's a national organization called, I think it's Mental Health America. They have a campaign that is before stage 4. And so the analogy is, people wouldn't knowingly wait until they had a stage 4 cancer diagnosis to get help. And when I first saw that campaign, I wasn't sure that it necessarily resonated with me. But this idea of how do you normalize things, and how, and I don't use this phrase as a political expression, but social and emotional learning. What does it mean to really understand the whole self, physically and mentally? So that's my pie in the sky, that I could talk about stubbing my toe, breaking my arm, having a cold, the way I talk about I'm dealing with depression, anxiety, or even a more serious clinical illness.
Sure. We've got.
I just want to add something on, if I could, to something that Carol said. I love that you're very interested in getting kids more help sooner. I completely agree with you. I want to also provide the input that it really helps to embrace the family as well in a non-blaming, helpful, informative, educational way. So many families get pushed away and they're left without the knowledge and the expertise of how to support their children. And we really all could do a better job of that. And families out there, if that's happened to you, please know that you can always talk to the providers, even if they don't feel like they can talk to you. And to the providers out there, if you're listening, You can always talk with families in a general way. You can say, hey, I can't tell you about your son, but in other instances of people with this diagnosis, what we find is blah, 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 blah. And here's some resources. More communication really would make a massive difference in the lives of the children and the families. And we all could be doing a better job with that.
Yeah, I agree. Thanks for calling that out.
We have about 1 minute. If anybody wants to add anything else. Otherwise, I'm
I
gonna.
would just like to say thank you for this conversation, everybody. Really appreciate it.
Yeah,
Thank
I
you
agree.
all.